Friends, Pradeep Pendyala, Professor of Anesthesiology at ASRAM Medical College, Eluru, City of Andhra Pradesh, India. Friends, today I am going to discuss with you one very interesting anesthesia topic. Not only anesthesia, it is relevant to ophthalmologists, it is relevant to surgeons, it is relevant to medical specialists, most of the specialities, even orthopedic surgeons. Yes, what could be that topic? It's perioperative vision loss. Very frightening, but it happens. Perioperative vision loss is a serious complication, friends, with medico-legal implications. That reminds me, I myself had a case when I was working after retirement at Mallareddy Institute of Medical Sciences. It was a case of spinal surgery, prolonged spinal fusion surgery, and we had put the patient on prone position and everything was going on well. But the thing which went wrong is that we didn't put adequate eye pad, and the eyeball was pressed on the ring on which it was being supported, and that caused temporary blindness, and it lasted for almost 2 days. And that really caused so much of anxiety in the entire surgical team. Luckily, patient was very lucky and we were also equally lucky. No medical legal complication, patient regained the vision. So that reminds me, perioperative vision loss could be very serious complication, and it could be of serious medico-legal implication. So what is this all about? The first thing which comes to my mind is, which I must say and share with you, is though it is rare, as I said, it has a devastating complication. Normally, it has been reported after spinal surgery, which I just mentioned, spinal fusion, cardiac or head and neck surgeries. Its incidence following spine surgeries exceeds that after cardiothoracic surgeries. Various causes attributed to postoperative blindness include ischemic optic neuropathy, ION, central or branch retinal artery occlusion, cortical blindness, and rarely external ocular injury. So there can be anything which can happen with these things. So let me explain each thing separately and in a very short form so that it doesn't become boring to you. And at the same time, it's very informative. As I just mentioned, ION is nothing but ischemic optic neuropathy. It can be of two types, anterior and posterior, obviously. Anterior is AION, anterior ischemic optic neuropathy, and posterior is PIO, posterior ischemic optic neuropathy. It can be arteritic or non-arteritic. Now, what is this arteritic and non-arteritic? ION is termed arteritic when it is secondary to inflammations of blood vessels, chiefly giant cell arteritis, also known as temporal arteritis. The term non-arteritic is used when it is secondary to occlusive disease or other non-inflammatory disorders of blood vessels. This non-arteritic is normally more common than the arteritic. It is found perioperatively. So let me tell me about other things about these things, about the topic of discussion. The most common cause of perioperative retinal arterial occlusion is improper patient positioning, resulting in external compression of the eye, as I had mentioned at the beginning of the discussion. External compression of the eye produces sufficient intraocular pressure to stop flow in the central retinal artery It is usually seen in spine surgery performed with the patient in the prone position. That's the thing. So, various factors could cause the patient to have this problem. It could be altered facial anatomy. It could have osteogenesis imperfecta like Southampton. But the biggest problem is improper patient positioning. The acronym CRAO stands for Central Retinal Artery Occlusion. CRA, the occlusion decreases the blood supply to the entire retina, while occlusion of the retinal arterial branch, otherwise known as BRA, is localized injury affecting only a portion of the retina. In most instances, this injury is unilateral. What is the thing to be more devastating and thing which has to be worried about? Emboli, though rare, can directly impair blood flow in the central retinal artery. And paradoxical embolism originating from the operative site reaching the arterial circulation also can have devastating effects. Fundoscopy examination is essential that shows opacification or whitening of the ischemic retina. You can have one computed tomography or MRI also that normally shows proptosis and extraocular muscle swelling, although most cases of imaging studies confirm the diagnosis which we are looking for. Orbital compartment syndrome causes compression of the arterial and venous circulation, resulting in CRA, an optic nerve injury. As I said, branch retinal artery occlusion causes permanent ischemic retinal damage with partial visual field loss. BRO is primarily the result of emboli and in few cases vasospasm. Ischemic optic neuropathy without warning signs is the leading cause of sudden visual loss in patients above 50 years of age. They could be adults, even children can report such problems. But what is to be, how it is the anatomic or physiologic variations in the circulatory supply of the optic nerve may predispose some patients to the development of EOL. A small optic disc may play a role in the subject's susceptibility to AIOL. And possible factors of perioperative ION include decreased systemic blood pressure, blood loss, anemia, and even hemodilution. Use of vasopressors sometimes are implicated. So you have to be careful when you are using, and even some people say the possible factors of perioperative ION could include decreased systemic blood flow, blood loss, anemia, and abnormal autoregulation in the optic nerve. Anatomic variants in blood supply and optic nerve can cause this problem. The biggest problem in this patient's and prone position, we have to be very, very careful when we are placing the patient on the prone position. So, prevention is very important. Corneal injuries can be prevented by common practice of applying lubricants and taping the patient's eyes prior to positioning. And most important is eye pad. Please do apply eye pad with lots of cushion. So that is how it has to be prevented. Please keep checking eyes intermittently where the patient is in the prone position. Don't take it for granted because of sometimes they keep moving the patient during prone position, the surgeons and the team. So initially it might not be pressing on the thing, but later it can start pressing on the eyeball and cause the problem. So keep on checking. If you can put a mirror underneath that can indirectly view the eyes on the headrest. That's a better option. So if it comes, what is the treatment? Please consult an ophthalmologist. That is the first thing I myself did. And management definitely consists of you must rule out intracranial causes of visual losses by magnetic resonance imaging like MRI. After that, frankly, there is no specific treatment. You can definitely give intravenous acetazolamide. 5% carbon dioxide and oxygen inhalation may help. And sometimes you can give steroids also. There is no specific definitive treatment. Diuretics such as mannitol or furosemide reduce IOP and edema. Benefit of steroids is not yet proven. Hypertension and anemia should be corrected. Most important is prevention. Thanks for patient listening. Have a wonderful day. Take care. Bye-bye. Until next time. Bye-bye. Take care.